start this presentation. So thank you, Maurizio.
Thank you for this very nice introduction. I would like to thank for the invitation to join this webinar, and I will share this lecture with Dr. Frontino from Milan. So I'm going to talk about this topic, about the role of unified care for the diverse challenges. The idea, what I will going to show in these slides, is the results of an Italian project, of a national project, which sees some collaborators from all the country. This is a project where different people and different specialties are involved. So we have a working group of expertise in heart disease, genetic disorder, endocrine disorder, diabetes disorder, and all of us have been granted from the European Next Generation Initiative, which gave us a grant to run a project about precision medicine in rare disease. In particular, the aim of this project are to create a model of precision medicine-oriented Wolfram syndrome type guidelines, which will specifically dedicated to diagnosis, follow-up, and treatment. Of course, one of the aim of this project is also to create expertise in this field and to create a rare diabetes clinic which can include all patients with rare disease, but overall individuals with Wolfram syndrome type 1. The aims of our project are highlighted, are listed in this slide. We have 3 different aims. The first one is to create a precision medicine oriented rare diabetes clinic, which can be not only in site, but also a virtual clinic for all individuals which cannot afford a so long travel across the country, or who cannot afford the expenses to travel. The second aim of our collaborative group is to start a project, a phase 2 project about the new drugs which can be used in individuals with type 1 diabetes, and that can be quite interesting in terms not only of blood glucose control, but also in terms of control on the other clinical manifestation of the disease. But Giulio will be much more comprehensive about information on this point. The last but not the least aim is to generate pluripotent stem cells from individual in the trial to attempt the production of insulin-producing beta cell, which will be very useful for experimental in the labs, but also for a clinical trial in the future, but not now, of course. As you know, rare disease have a very important barrier, which is represented by the lack of knowledge in the healthcare professional. So one of the object of our project is to overcome the barriers to implement effective precision medicine standards in clinical care, especially in rare form of diabetes-associated syndrome, because the lack of expertise across the country, but also the number of individuals with this disorder, which can be a limit to implement in clinical practice this care. When you have a people with such rare disease, you have some steps to face. The first one is the diagnosis of type 1 diabetes, which at the beginning seems just type 1. But when you go on and when you work up on the differential diagnosis, you find that this is not a classical type 1 diabetes mellitus, and thus it is a rare form of diabetes, which can be accompanied in the follow-up by different clinical manifestation on eye, neurological signs, but also, as you know, other clinical manifestation. And all in all, this is a very heterogeneous disease. So the problem is not only to face the diagnosis and the different clinical manifestation, but also to face and to effort the different needs of each individuals, because this is a disease, there is a disease heterogeneity. The fourth step, which we have identified, is the need for a multidisciplinary team, because this is a multidisciplinary disorder which requires different expertise and has different health, clinical practice, professional care need to be involved. Of course, the last step is the need for a specific treatment. We have treatment for each disorder, for each manifestation of the syndrome, but we still don't have a specific treatment which can stop or at least to slow the etiological mechanism underlying the disorder. This is the list of the operating structure that we think should be involved in a clinical center for Wolfram syndrome care. And you have, of course, the most important figure, which are pediatrician and the expert in diabetes, because these are the main feature of the disorder, but all the other field, all the other experts are involved in the care. Expert in endocrinology disorder, neurology and physiology, the eye disease doctor, otorhinolaryngology, nephrology, psychology, gastroenterology, internal medicine, intensive care, and of course, medical genetics and neuroradiology expertise, because this is not a simple disease, but this is a syndrome which have a different clinical manifestation, requiring, of course, different figures which have to be involved. In the part in this slide, you can see what is the role of each specialties and what is the role in a multidisciplinary team. So let's go to the aim of our project. As we have already said, the first one is the precision medicine oriented rare disease clinic, which can be collect data and does also to collect expertise for the disease to improve as much as possible the care of these individuals. Of course, when you have a specific clinic for a specific disorder, you have to start with a specific clinical follow-up and laboratory and instrumental examination, which are fundamental not only for the diagnosis, but of course also for the follow-up of all the needs of these individuals. The second part is of this aim is to create a close collaboration with the research facilities, because they can give us very important information about the diagnosis, about the physiopathology, about the prognosis, and of course, to implement the follow-up of this subject. Of course, this rare disease clinic can also facilitate the recruitment of more subjects, and thus to support and to implement any research project which can provide very interesting insights for improvement of clinical care. This is my part, and that's a pleasure to leave the word, the last part of the speech, to Giulio.
Lovely, thank you. Giulio, if you'd like to continue.
Yes. I'm sharing my, do you see my presentation?
Yes.
Okay, perfect.
Thank you.
So as my colleague Maurizio just explained, the rare diabetes clinic, the creation of the rare diabetes clinic is fundamental and must be accompanied by a biobank for the sampling of biological specimens. As we mentioned, as Maurizio mentioned before, it is imperative and it's very important to collect both clinical data and molecular data as our aim is to create a precision-based clinic. So being the Wolfram syndrome, a very heterogeneous and both with respect with the single mutation, but also with the different manifestations within the same families with the same mutation, we cannot not include biological sampling and biological testings on these samples to improve the results that can be parallel to the clinical data collection. So the main objective is to both establish the average mutation-specific, and it's important to underline mutation-specific natural history, and being the sampling program at follow-up. So we will not just take samples at diagnosis, but also during follow-up, we will also have a molecular natural history of the disease. So the biobank is important, and this biobanking, of course, being it a rare disease, should represent a very efficient way of using samples within different research projects. So a single sample may be used for different research purposes, and as we said before, the clinical approach is multidisciplinary, but also the research approach can only be multidisciplinary, as both inflammation is involved in Wolfram syndrome, as well as other molecular mechanisms, which include the ER stress, or the cell stress that is derived by protein trafficking in the cell, but also calcium homeostasis, so calcium trafficking, and the cell bioenergetics, which involve the mitochondria, which are practically our energy-producing parts of our cells. So we have clinical banking with clinical aspects, biosampling, so a biobank, and both banks will be multidisciplinary in nature in order to collect the most data possible, and with the most data possible, have the most efficient and valuable results, of course, because valuable results come from a very high quality, but also high quantity amount of data. Going to the other great obstacle, which is treatment. So coming from data collection to what we may do with all the data we collect is, of course, treatment, which is one of the major obstacles of Wolfram syndrome. And of course, until now, the main treatment course of Wolfram syndrome type 1 has been mainly a symptomatic treatment or a hormone replacement therapy, especially for what concerns insulin-dependent diabetes mellitus, with, of course, insulin treatment to substitute for the insulin deficiency. And of course, also the same goes for other endocrine diseases. And we've seen that, for example, several cases of growth hormone deficiency, thyroid hormone deficiency, and both testosterone and estrogen deficiency due to both central and peripheric gonad deficiency. So hormone replacement, of course, is currently the only possibility for now. And of course, for unfortunately the other neurological conditions associated with Wolfram syndrome, no proven treatment up till now has been possible. Some data on coenzyme Q derivatives. Coenzyme Q is a molecule that's very important in the production of energy in the mitochondria of our cells, and it has been extensively studied in other optic nerve diseases such as Leber's dystrophy. And it has shown some effect in the reduction in the progression of diseases such as Leber's. However, data are lacking in Wolfram syndrome. although coenzyme Q derivatives have very few side effects, if any. So coenzyme Q may be proposed to improve the mitochondrial dysfunction part that may be involved in Wolfram syndrome. Unfortunately, for sensory neural hearing loss, no direct treatment has been, of course, been extensively studied, and therefore, in this case, no drug has been identified to reverse or to reduce the progression of sensory neural hearing loss. So therefore, hearing aids and eventually cochlear implants, unfortunately, are the only solution to this severe complication. So up till now, there are several pipeline treatments studied, as we can see from the treatment pipeline, the latest treatment pipeline on the Snow Foundation website, the Wolfram syndrome website. And as you can see, there are many. If you consider if you look on the left, the three main subset of type of interventions we can foresee. There's treatments that aim to prevent progression. There's treatments that aim to protect and regenerate the damaged tissues and cells. And of course, the main focus and the main objective is to replace the pathogenic genes. But of course, the third intervention will entail longer studies due to the fact that the gene therapy is already used in other rare conditions, but in Wolfram syndrome, it hasn't reached the clinical phase yet. If we focus on those that are the drugs that have been studied for now in the clinical phase, so on patients, on humans, you can see that the main drugs that have been studied are those that are called repurposed drugs. And drug repurposing has been lately, in the past several years, has been a big chapter of quick production of new old drugs, because drugs such as valproate and phenylbutyrate acid and Todica, which have been already used also in pediatric conditions, have been extensively studied, especially on the safety side, and therefore can be translated to other conditions which may be considered off-label for disease, but are still in label, especially if you consider the pediatric age and their pediatric indication. So, for example, dantrolene and valproate have been extensively studied, and other drugs, combination drugs such as AMX 0035, which is a combination of older drugs, which are phenylbutyric acid and Todica, which have been extensively used in other pediatric conditions, are considered a good candidate or candidates if you consider the combination of their effect, especially for what you can see in the second column of this graph, which are the main steps that can be approached in the molecular mechanisms of Wolfram disease. And as you can see, most of these act on ear stress and the mitochondria, as we mentioned before, with coenzyme Q. And some may also have an effect on cell regeneration. And as Maurizio mentioned before, we have been focusing especially on one class of drugs, and especially on one drug lately, which is one of the aims of our project. And the class of drugs, if we consider the data that has been produced recently by our collaboration, by our collaborative effort, is our GLP-1s. We have been focusing on GLP-1s as they have been extensively used in the past, especially in the treatment of type 2 diabetes. But in their history, they have been shown to have a multitude of effects on several tissues and organs, and a multitude of beneficial effects, especially if you consider neuroprotection, which is one of the main focuses of Wolfram syndrome research. And as you can see, since the first GLP-1 receptor agonists, such as liraglutide, which most of you may have heard as Victoza, which has been, liraglutide has been maybe more as Saxenda as the weight-lowering drug, probably. Liraglutide has been extensively studied as in type 2 diabetes, as I said, but also for its neuroprotective effect. And it's been kind of an epiphany in the past because the first data on neuroprotection have emerged in studies with older patients with other neurodegenerative disease, such as Alzheimer's, who also had type 2 diabetes. And what was seen was that people with Alzheimer's disease and type 2 diabetes who were treated with GLP-1 receptor agonists had a better progression in their neurological disease with respects to other people with Alzheimer's disease, who were treated with other type 2 diabetes agents, such as metformin or other hypoglycemic agents. And as you can see, due to this sort of epiphany, other newer GLP-1 receptor agonists, such as semaglutide and dulaglutide, which is one of the latest, which is also more comfortable to administer because it's a one-weekly administration. Although it's quite new as a drug, it has already accumulated some evidence for its effect, also not only on type 2 diabetes, so not only on glucose metabolism, but also on neuroprotection. And we must also underline that the fact that they are the anti-diabetic agents, which have been used in type 2 diabetes, they have also been used in type 1 diabetes to improve insulin sensitivity and so cellular glucose metabolism. And the fact that these drugs also have an effect on the diabetes and glucose control in general, be it in type 1 diabetic patients or type 2 diabetic patients with type 2 diabetes, the fact that glucose control improves is already per se a potential indirect effect on neuroprotection, because as we all know, glucose control affects systemic inflammation and may worsen neurodegeneration. So the effect of GLP-1s may be both direct, with a direct effect with the interaction with the GLP-1 receptor on neuron cells, but also indirectly by improving glucose control. And a newer class of drugs have recently arisen, which are called dual and or triple agonists. Dual and triple, because if you consider the drugs I mentioned before, they only act on one receptor, so they're agonists for one receptor, which is the GLP-1 receptor. And these new drugs act on 2 or 3 receptors on the same cell, and with a cascading and multiplying effect on different mediators, intracellular mediators, as you can see on the table on the graph on the right. And just to summarize a bit, you can see at the bottom of each strange acronym, which are intracellular molecules which are involved in inflammation, cell death and cell survival, DNA repairment. All these effects seem to be boosted by the action of these drugs on all 3, or at least all two or 3 receptors. And although they are quite new and they have been studied for only maybe 2 to 4 years, they're already accumulating. There's already accumulated evidence of their effect on not just type 2 diabetes, not just weight loss, but also inflammation and neurodegeneration. And and that is why we are focusing on these new drugs for our project, since we have had some data, some preliminary data on single agonists on the apparent stabilization of the optic nerve atrophy. And although there are very few data and it's hard to determine a real effect with those few data. But we believe that although there are few, the data that is also present in other neurodegenerative diseases supports the fact that they could be very good candidates, especially since they also have very few side effects. First of all, the main side effects are gastrointestinal, they're transient, and so one of the main questions that parents and patients ask are the fact that since they're weight lowering agents, they're afraid that their child may lose too much weight. But they're quite safe, and they're dose dependent. The effect on weight is dose dependent, and usually it's transient, especially at the intermediate doses. And with the experience we've had with our children and young adolescents is positive, and the weight has been maybe only initially decreased, but then slowly increasing physiologically. To conclude our talk and to sort of concretely express our project, we submitted our expert consensus with the support of the Italian Diabetes Society, both on the Adult Society and the Pediatric Endocrine and Diabetes Society, both Italian. And we published an expert consensus with our Italian colleagues, which have historically have had experience with patients with Wolfram syndrome, to underline the need for the standardization of care in the management of Wolfram syndrome, and underline the fact that the diagnostic criteria need to be updated, since, as Maurizio mentioned before, it is a very heterogeneous syndrome with an onset and we have seen this in the same families with a different onset of symptoms, which not always involve type 1 diabetes and clinically relevant optic atrophy. So this certainly may cause a delay in diagnosis. And of course, with an earlier diagnosis, we may envision a more tailored and earlier treatment, maybe even with off-label treatments, which are personalized thanks to the biobanking and the research that may be envisioned with the use of iPSCs, so beta cells and neural cells derived by patients, so with the specific mutations, and eventually humanized animal models. We have seen many studies with mice with Wolfram syndrome mutations, but they all have the same quote-unquote mutation, which may not specifically represent that of the patient, especially in terms of manifestation, molecular mechanisms, and progression. So the possibility to use biological samples of the patients to create animal models which have the patient-specific mutation will certainly speed up the process of finding new drugs which can be tested for that specific mutation in an animal model that represents as best as possible that patient or that group of patients. So in conclusion, this whole expert consensus will underline the fact that we are still a big unmet need is the fact that we need holistic care, a holistic care model in this syndrome, as with many rare diseases, which addresses not only the medical side of things, but also the psychological and social challenges which all of these families face daily. With this slide, Maurizio and I have finished our talk. So
lovely.
We're not too late.
No, we're good. Thank you. So I've got a couple of questions that have come up. So one's more a comment. So Dr. Arano in America has said that he agrees that we need to create consensus clinical guidelines. And he sort of says about, let's discuss this via Zoom. So obviously that's something that you can arrange between yourselves. We have a mum. Do you see a complete stop of progression, or does it still worsen over time, even with GLP-1?
It's as I said before, it's hard to be, I don't know the English term, I know the French term tranchant. So it's hard to be conclusive, because we have treated a few patients. Up till now, it has been 8 children between the age of 2 and 16. And it's hard to say. From what we have seen, there apparently has been a slowing progression, but we don't know whether this is the natural history of the progression of the optic atrophy or the effect of the drug. So the only way we could sort of increase our knowledge and discern whether it's the natural progression of disease that sort of progresses quickly in the beginning and then more slowly while the optic atrophy worsens, would be to use what they call an N=1 trial, which is to use the person with Wolfram syndrome as the control of itself. So to start the treatment and then to suspend treatment to see whether the progression increases when the treatment is suspended. But it's quite hard to envision something like this, to propose an off-label treatment, see some sort of reduced progression, and then to suggest to suspend the treatment. So it would be the optimal condition, but it's quite hard to propose something like this to a family, and it's easy to understand how a family might find themselves in a very difficult situation to decide to stop a treatment, especially if apparently some sort of beneficial effects have been seen, both in terms of diabetes control and maybe optic atrophy progression. And that is why the biobanking and the clinical registry are so important, because this enables us to collect the most data possible, maybe clustering groups of people with the same mutation, understanding the clinical progression, and that will help us to maybe clarify these doubts that we have in these small studies and small clinical experiences with off-label treatments.
Lovely, thank you. I have seen this is one of the benefits of having a presentation with 2 of you. Maurizio has been able to answer some of the questions that have come in as well, so that's really been quite handy. So thank you. Well, we've had another one just come in. Professor Barrett says, great opportunities to pool our expertise in delivering clinical care to patients. Would be very happy to share our experience of delivering national Wolfram multidisciplinary clinics. I don't know if you're aware, here in the UK we do have multidisciplinary clinic, which we have for both the paediatrics and the adults, which is brilliant for all of our patients. I just want to quickly say that here in the UK, we actually are having problems with obtaining liraglutide because of it being used for weight loss. So we are having to look to find alternatives to help those of our patients that have been on liraglutide for some time, but I'm sure we'll find a way. Lovely. So thank you very much. I'd like to thank both yourself, Giulio, and Maurizio for your time and giving our presentation. Just a reminder, if there's any questions that any of our community think of after this presentation, then drop me a line. We've just had one come in quickly. Have you seen any patient losing their vision although taking GLP-1 for years?
Unfortunately, yes. And the answer is more or less the same as before. Unfortunately, the patient that lost vision had already a very, very, very low vision to start with. So we don't know whether we needed more time. Of course, the timing of treatment is essential with all diseases. That the timing is important, because if we want to preserve or regenerate, first of all, we need time, and we don't expect GLP-1s to be a quick, to have quick results with GLP-1s. So of course, the other factor that comes into the data we have is that maybe we don't have enough time of follow-up to see whether it's a stabilization or not, and maybe we need different doses and maybe a different GLP, because we talk about GLPs, but it's not necessarily a class-specific mechanism, but a molecule specific. So we can't. So not all GLPs may be interchangeable. There's liraglutide, there's the dulaglutide. They might cross the blood-brain barrier differently, so they might have different effects. Because some patients, as you said, have had some trouble finding liraglutide, and they've asked for dulaglutide or semaglutide since they were easier to find. And it was hard to give an answer on whether it would be the same or not, because we don't have data. It would be a long shot anyhow. So the answer is that the loss of vision we've seen probably was due to the fact that, unfortunately, the GLP, probably, we can't say for sure, was started too late. But that's why the early diagnosis is so fundamental, because all interventions must be, when possible, and with all the safety issues considered, started as soon as possible. Otherwise, it's hard to envision an improvement.
Okay, lovely. Thank you so much.